hospital building, and they have a whole department just for nurses
Really?
to do HIM coding for rejection and medical necessities. And I kind of felt like putting my hand on my head, like that's not fair. So you're right. Because some of us are experienced. Like I come from, I was a medical office manager for 5 years in a special needs hard to place group home. We had 75 beds. So I think that's what that interaction, direct care, and working through that office. I think I'm qualified to know what medical necessity is, but I guess some people don't think so. But I was talking about that a little bit when I get hired.
Look, I'm in my feelings right now. I don't understand. I don't.
I think I have an idea of medical necessity. You know, so I go to that's probably what they would do with that now. And I'm here in New York, they have hospitals open, etc. But the special deal that that's
No, absolutely not.
it makes me consider going to that study just to be like,
Jesus.
but yeah.
It just goes to like my word of the year. My word of all of 2022 is going to be gatekeeping. Because that's all it is.
Yeah.
That's all it is.
They gonna have a whole little setup and section. Like, wow.
I worked in child. I worked in children oncology,
Okay.
and I thought when I started studying for my CPC and taking classes, I had to take anatomy and physiology and all of that. So initially, I'm working with them, and you would think, oh my goodness, pediatric oncology. This is like the top. No offense again. Anybody listen? This is like the top of the line. These are like the best, just like cancer and chemo children. And they look at me as like blank spaces. Why do you have to take physiology and anatomy for coding? And I just kind of looked at them like, are you serious? Like, what would I be coding? If I'm reading your notes, your doctor's notes, how would I know what parts of the body to discuss?
Exactly.
If I didn't know. So when I see even their numbers, like even their salaries are higher. So for me coming in, we're talking 25 to 30. The nurses per hour, and they're only, I thought it was also ironic. I think it's like part-time or contracted.
Okay.
They immediately starting at 40 to 60. And that like really threw me. Like, really? I can have more experience, but because you came with this educational background, somehow you got paid more coming into the work. So I was like 40, 60. I was like, I need to look into a LPN program.
I'm so glad you said that, because let me tell you, as an LPN, with even me being an LPN, with all of my experience, your hospital, that same hospital would not hire.
Wow.
Not an RN.
And some of those RNs don't. I was telling them because of my experience as it was a little bit different. It wasn't a typical medical office manager. I had a lot of hands-on because I had worked there prior years, and I knew my like I call them my kids. I knew my kids. I knew a lot of their medical history. I have been to appointments with them. I've known some of their specialists, so I had a lot of hands-on experience. But which is good to be able to work with 24-hour nursing so that you can help, the nurses as a team. But to come out of that and have people kind of talk down to you, and it's just like, what are you talking about? I went into the pediatric oncology unit, and I really feel like they didn't like me at all because I knew more than clerical secretary or whatever. I understood even the sociology about it. Like, you can't talk to parents all kinds of way about their kids. You kind of have to use some sensitivity and compassion. It's not just medicine. I was the one that detected a child abuse situation with a parent. I said, she didn't double talk twice. You asked her the same question twice. She asked her the same question twice. She told you 3 to 4 different stories. Did you not catch that? She's lying. She's like, one lady that she came in, the child's IV came out twice. There's only you and the child in the room. Who's taking the IV out? Why are we not concerned? So like little things like that where a nurse is like, I'm like, ding, 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 red alert. Everybody gets concerned, like, this is a problem.
And the reason why they're not concerned is because, believe it or not, they really don't teach Munchausen syndrome in nursing school. That's not one of the core topics, but it is a very real thing.
It's a very real thing, and if you don't know, they don't even really teach abuse and how to detect abuse, how to report abuse, and medical professionals are mandated reporters as well, but their experience to it is very low. So again, here I am on a pediatrics ward, and I'm seeing crazy stuff happening.
Wow.
Y'all don't know this is not good. You don't know that they're going to come back to you and say, why didn't you say something? And they're looking at each other and they're looking at me and they call their nurse manager. And I'm like, and she's like, yo, she's right. She's absolutely right. I'm like, gee, thanks. I kind of knew that, but okay.
Wow.
Yeah, so, but yeah, that's kind of where I am with it. I'm just excited to keep it pushing. But I'm definitely looking. I think, in New York, they're offering some scholarships for nursing programs. And I think we have an LPN program, at least one, still here. So I'm highly considering it.
But Asha, let me tell you, if you're going to do it, don't do it. Just go get your RN. Don't do the LPN. I'm telling you.
And I know here locally. Oh, I'm sorry. Go ahead.
With the credits that you have, you should be able to, like the courses that you've taken, you should be able to move further along into the program.
And I know we have a lot of programs that have been sprouting up recently that are like, if you don't have the clinical background or you haven't started in a clinical background, you can get your nursing. I don't know how it works, because I know someone who actually went through the program where they were in like supply chain, and I think they already had a bachelor's degree.
Yeah.
And so I guess you just get the clinical pieces, and I don't know what that program looks like, but it's like a 16-month, 18-month something program that propels you into your RN.
Mm-hmm. You get a BSN.
Yes. There's lots of those that have been sprouting up here recently. I don't know if that puts you into going into the nursing field or just having that title or what have you. I mean, I don't know what all it goes through, but yeah, there's a lot of those.
When you finish, you are a registered nurse and you have a Bachelor of Science in nursing.
Okay.
Your original bachelor.
So then you would have to do like all the clinical pieces or what have you in order to get your license piece, or is that separate, or is that included?
Once you complete that program, you just take your test.
Oh, okay.
The program has the clinicals built into
It's still built into it. Okay.
Mm-hmm.
Okay. Well, yeah, I know they have a whole bunch of those bridge programs that are, trying to, because they understand the nursing shortage, and there are people who are somewhat interested or on the fence, but this allows them an opportunity to take some of the, like you said, Mr. Jesse, some of the coursework and some of the classes that they already have and apply it to this particular program or these programs, so that you're not starting all over from scratch.
Yeah, I thought the LP, I don't know any RN programs off the top, but I do know I applied for a lottery for the RN program in New York State, but they were just for it. But I do know of an LPN program that's it's just under a year. And I kind of felt like right now, if it was something I was going to look into like for September, I'm in the best place with what I know where it wouldn't be really stressful, because I've already done like whatever they're going to give me again for anatomy and physiology and bachelor, like I've already done that.
Okay.
So it'll be more of a review than it would be like, oh my goodness, I really have to study to pass this. And like you said, I already hit the credits. So
no. You will have to study, because like the pharmacology that you have for your program is different than pharmacology
for nursing.
The nurse program, because like they get down into like you have to know the chemicals, like why. Like to this day, I remember what Zantac does. Zantac inhibits hydrogen ion secretion in the stomach.
And I didn't say pharmacology. I said physiology.
I
don't know anything about pharmacology.
Okay.
Still better than totally nothing.
Right. Okay.
Like usually for those placements, they ask you if you either already taken anatomy and physiology, or they do like a placement test, and it's usually anatomy and physiology. So they want to know that you've at least done that and passed it, and then they consider, whether or not they'll put you in the program. So that's why I was saying I think that for me would be good, because I did that.
Well, if that's what you want to do, just make sure that you have to still go back and just as soon as you get finished that, transition into an RN program.
Okay.
And let me just say, I'm still in my feelings that you have to go these extra steps and extra miles in order to be considered for some of these positions that are truly HI positions. I just, I'm in my feelings. But
really, because I'm telling you, like, and AAPC really should address this as organizations, because it is a slap in the face.
You're right.
You have people, and I'm telling you, I've had nurses reach out to me. I've had RNs who get CDI positions who don't know jack about coding, and they want to crash course. You can't crash course this. You have to. It takes time to learn.
But I don't understand why so I think it's another piece of it is why the powers that be, not necessarily the organizations, but why the powers that be in these facilities and these healthcare organizations don't recognize and realize that team concept, and that yes, we can have nurses, yes, we can have coders, yes, we need a physician liaison. Yeah, there's so many pieces to that puzzle, and why not staff for the realm of it? Why not staff all those pieces versus thinking that, oh, a nurse can be the end all, do all?
Well, I don't think they know any better. I think it's becoming a lot of the schools, unfortunately, that are supposedly medical schools. They're just like those like hybrid schools that only teach you one topic. So somebody will look at somebody like me and go, "Oh, you learn billing and coding." The different schools that teach a different quality of billing and coding, and then of course the student and what they walk away with, not to mention their background experience, etc. I happen to be different, where I have a medical background that could be appreciated by somebody, not necessarily everybody, but by somebody, because I've been in certain spaces. But they don't look at that when they look at a nurse. If you just come in and you're a nurse, or you just come in and you're a doctor, there's an esteem to that. So,
and you could be the worst nurse in the world, but as long as you walk in the door with the
absolutely. My grandmother's a nurse, and when I started in the hospital, I called her. I said, "Listen, what is wrong with y'all people? Come get your people." And I'm West Indian, so I said it with a whole nother accent without laughing. And especially when I started working in the group home and I had to help to manage nurses, and I'm not a nurse. So I do their time, I do their schedule, I interview them, I place them, and we did 24-hour nursing. Some of them were so wicked because I'm like, your money is my money. Listen, we're moms. We gotta do this. We gotta make this happen. These are kids here that I really care about. If you care about them, and I care about them, let's make this happen. I just need to come to work. And they were fine. But then there were some nurses that were very upset at the idea that I was somehow supervising them, or I was somehow hiring their peers, and they couldn't get past that. And, it made it difficult until they wanted something, and they're like, "Oh yeah, I should have fixed my hours. Yeah, maybe I'll get to it."
Wow.
Now I have to push back a little bit because, I have all the pizza parties, all the nurse appreciation, all the everything, thugging it out when the administrative side for you. But when you got to thug it out for me on an everyday moment to make sure kids get medicine on time, they're ready early for procedures, you're giving me crap.
Right.
So now I gotta play this role to make this thing happen, to make this thing work, to make you see that I'm just as important as you. When I'm not here, when I left, they called me back just to do clerical. They were like, "This is not working." But you don't want to do this.
I really want to. Clarice, like to your point about nursing, especially when it comes to employment. Nursing, I've been an LPN for almost 30 years. Nursing is gatekeeping 101. I'm telling you, if you listen to any Black nurses, because just like coding has all these different branches, so does nursing.
Okay.
Nursing has a fundamental core education.
Right.
Coding has a fundamental core education. Then you go and you specialize. If you want to go work in telemetry, if you want to go as a nurse, if you want to go work in if you want to go work with pediatrics, all you do is then at that point, you drill down a little more into certain technical things, but you still draw off of your base knowledge. So you learn a few extra things. There are so many Black nurses right now in this country right now who complain about not being given opportunities to transit into ICU, to work in
Really?
to work in critical care, because work in critical care and ICU, your money almost doubles compared to
PICU nurses is a lot of money.
Wow.
So they complain, and this is people who have the exact same education of it. We're not talking about RN. Okay, I'm talking about RNs who have bachelor's degrees and master's degrees. They apply, go to units, and they never get it. Or if they get in, they have to face all these microaggressions, so they end up leaving.
That too.
You look at, but one more thing. If you look at Adidas, they had, I think they had some kind of conference in April, or maybe it might be coming up. If you look at everybody who was presenting, almost everybody who was presenting was a registered nurse, and they only had the CPS credential. Most of them had those two things. That's it.
Wow.
So he who pays the paper calls the tune.
Hmm.
Wow.
I need some tea. Hold on.
No, it's true. Because they don't like you. They know that you can help them and you can cover them. You have to play the game. You know, you have to play the game. You have to play, Starbucks. Everybody wants something, but you gotta play. And I wasn't that girl. I didn't come there for that.
Oh, the whole code shifting, I'm gonna need something stronger than tea today. I need a mimosa.
I'm telling you.
Oh.
People have no idea. And I really think that it's up to, this is up, once again, this is an organizational, I want to say industry level issue that needs to be addressed.
You're right. You're right. And so I'm feeling, a couple things are going through my mind right now, particularly from my AHIMA hat. I don't have anything to say really about the AAPC hat yet on this, but particularly from my AHIMA hat, because what our leadership looks like. Our leadership in AHIMA looks like us. That needs to be addressed. That needs to be addressed. Now, I know she hasn't. Her background is not health information. She did not come from the ranks of health information. As she took the reign of the organization. However, I'm sure I probably could bet everything I own that she has experienced at least some of these same types of issues in whatever field, in whatever industry that she came through. And it needs to be addressed. It needs to be addressed. It needs to be addressed.
On an industry level.
You're right. You're right.
It is rampant. I'm telling you.
You're right.
Getting worse.
So I think that if we can encourage our younger generation to consider these professions, because there's a grand exodus. I just think all it's going to do is transfer from literally hospital bed care into where we're doing more clerical administrative nurses. And at some point, it's going to move from that too, because these people, everybody gets older, and everybody wants to retire at some point. They just want an easier work, because COVID made bedside nursing went from a breeze, a breezy shift depending on where you work, to a life or death sentence.
Right.
And not being able to go home right away, or going home and even being displaced because you're working in a COVID unit. So it really made it a different level of political. If you weren't everybody's friends in the hospital, you might be the nurse that always got transferred to a COVID unit. So it changed and leveled out some things in the hospitals and made it real gutter. Before, you're talking about changing bedpans to now just working in a COVID unit because your nurse manager does not like you. That's what we're dealing with. So I think that it's going to change.
Oh my God.
We have to encourage our young people, our next generation, our mid, when people are changing, maybe leaving state jobs and they want a second career, to get into or encourage these scenarios so that you can, be a voice. Because if you don't have somebody that looks like you that can be a voice, then nobody's listening.
Right, but that's not going to address the gatekeeping, because what you said was true. You have people who are going to leave nursing. Like I read somewhere this year they estimate that 500,000 nurses are going to leave the bedside. And I believe it. But where are they going to go? They're all going to sit home and start volunteering at their children's school. They're going to still need employment. And this is when I say it's going to get worse, it's because those nurses are going to start to transition to HIM. They're going to have an easier path to employment. They're going to have an easier path to better paid jobs. Then at that point, if you're not a nurse, to get advanced, because they're going to be flooded in the middle and the top level, and you're never going to get up. So people need to address it now because it's coming. I'm telling you, I see it.
But private building companies, the more we go into private building collections, the more you see those opportunities opening up, which is why I'm looking at it like, wow, like there's already a whole unit in this large building, and all they do is hospital collection through the tri-state area, and now they're moving into Florida and California. So imagine the nurses that they will be able to scoop up who already are degreed. The only thing, like my angle was good for me because I've been in the hospitals already. So I can actually probably, once I get in there, even negotiate, maybe this is a good place for me because I know the person that hired me doesn't know hospital stuff.
Mm-hmm. Mm-hmm.
So I could see how that for me could work, but that wouldn't work for another person coming in. But a typical biller, typical coder, it wouldn't work for them.
But but the part that I find so aggravating is they take these nurses. You might have a clinical background, but you still have to be taught coding. You still have to be taught God. You still have to be taught criteria. You have to be taught what medical necessity is. Especially at nursing school, they don't even mention the words medical necessity because it does not matter.
It doesn't.
Part of the model. That's not part of the model.
Right.
So you have to be taught. So if you can teach these clinical people non-clinical things, why can't you teach not the non-clinical people clinical things?
Exactly. But to your point, you have those protocols, you have those clinical protocols and pathways providing that information. We can follow a map. We know how to do that. We do that all day.
The difference is the main issue that people are not addressing is the money. That's the piece where you lose out. Because I'm telling you, I worked at a company 6 years ago, working remotely. This company only hired RNs and LPNs. There were RNs 6 years ago working from home making $90 a year.
Wait till because I'm so frustrated right now. And believe it or not, we were going to talk about health information career paths, but we didn't. I'm gonna somehow try to segue back to that. But right now, so as an advocacy leader in my state, it's about to be on. We about to shift all of this. My mindset was following some of the things that we know to be true that are still beneficial, like advocating for the patient ID, advocating for social determinants of health. All are beneficial, all are necessary, all are great things from a national level. But wait till we have our next meeting because it's going down. Can we talk about this other elephant in the room? And that is how and why we now must compete against others, nurses, and it's not new. I remember this way back when I started in this profession over 20 years ago. It's not 1993 to be exact. 91 is when I started. Got my first degree in 93. It was going on then. So why is it still here?
You know what I mean? But a lot of people coming in through these programs don't know that they're going to compete with medical professionals.
And they don't. They don't have a clue. You're absolutely correct.
And they don't understand understand even the range. So if you go into the social media pages and you see people who are studying or passing coding, and even my classroom, and they were like, "Oh, take whatever you can get." There are people in schools that are telling students to take what they can get.
That's garbage. That is absolute garbage.
Do not do your research in this career space. If you're going to be spending all this time to study, you're going to be getting a certification with some letters behind you. You're telling me you're going to get paid the same amount and you're good as the guy that just gave you your burgers in the Wendy's drive-thru? I'm sorry, sir.
That's garbage. And why should we settle? Why should we settle for some crumbs when we can go get the whole cake? No, that's garbage.
If you don't know any better,
and you're right.
any other field, you're gonna settle. And I was, the a-hole in the group, and I was like, nah, that's not what I'm gonna do.
Thank you for being the a-hole in the group.
They said I was, too direct, hard, whatever.
Aggressive.
They'll go, "Oh, Ashley, so what do you think? What are you doing? How do you know?" I said, because my research in this field was to literally just go out on crazy interviews, even if I didn't think I was ready for the job, because I knew nobody was going to tell me because the information is in Google. So let me go for that job.
Is that a word? Wait a minute. I'm about to write that down.
Your new title is not a-hole of the group. Your new title is change agent.
Yes. Yes. Thought leader, change agent. Amen. Good morning, Molly.
So, Molly, would you like to weigh in?
It's a little noise over in my household, but hi, good morning. I wanted to say, because I'm in an AAPC group on Facebook, and I think a lot of the instructors are not preparing them and letting them know, like, it's going to get rough out here, because they think, okay, I'm certified, I'm a builder, I'm a coder, I can find any job, I want. You can, but it's going to be hard. You got to do your research, because they're fresh out of school and like, well, I can't get a job anywhere, So I think the instructors need to just prepare them a little bit better mentally going out into the, the healthcare world.
But what's the drawback for the instructors to do that is that then you're almost compromising your program. So if it's about you looking at the bottom dollar, because I agree, but I feel like the instructors, especially for the private AAPC teachers and so on, they kind of don't necessarily want to do that because they feel like if you tell the person, oh, you might, one, you have to do your own research and give them opportunities in the industry. Two, you're either going to discourage them, which means you're going to change your bottom dollar. And I think that there are a lot of instructors that just want to teach, just want to make the dollar, just went and got their certifications to teach and make an extra stream of income. And they really don't care about their students and how far they progress. But they don't. They don't want to be to give the nomination or to they don't have their foothold still in the industry where they can say, I worked at this hospital, I know an HR person, I know a coding department head that was hiring. Like, they don't have those resources for their schools. And I think young people who are going to school need to find instructors like that who really care.
Yes.
I don't want to put that on the I want to put it on the institution, because how it works in college, your professor does not help you get a job. Every college has a career center.
That's true too.
They have with employers, industry, and they refer you, because believe me, when you go to certain colleges, you can interview with certain employers.
Right.
So these schools need to have someone in career services. They should know locally who hires or who is hiring, who would be willing to hire a newly certified student from this school based on their reputation.
Mm-hmm.
That's the job of the school, because most teachers that they just teach. They're not. Some teachers haven't applied for a job in 30 years, so they have no idea what it even takes to even get
Right. I was going to say that some of them may, especially if they're a career teacher or career professor or instructor, they have no idea what is happening. Um, it took forever for a lot of them just to transition over to an electronic medical record and be able to to navigate that and teach us, because they don't necessarily have any experience with it. They haven't used it. The only thing they have is the simulation that they are using in their classrooms. They have absolutely no experience. So they may not even be in a position to assist, but we definitely need to find a way, Asha, to your point, and Molly, to your point, to make sure that our folks understand and know, what they may be facing and how to overcome those. And because, we are truly a people of overcomers. We are truly a people who will not sit by idly and just let things happen to us. We often pave the way. I saw a quote. I can't remember the full quote, but it's something like, if there is not a path there, then you make the path and let people follow you. Those are the people, that's the stock we come from. And so we know, unfortunately, that's sort of the mindset. Even as you mentioned, Mr. Jesse, about the whole gatekeeping thing, this gatekeeping foolishness has been going on for years. And sometimes you just got to knock that gate over and keep it moving. And you would think, at some point, some of these gatekeepers would be transitioning on as retirement or going into another field. But like you said, they're taking those same gatekeeping skills and bringing that foolishness over here to health information. And I'm absolutely not going to have it. Not the profession that I love and been involved with for all these years. It's ridiculous. We're not doing that. We're not going to do that.
Because I've complained on this platform ad nauseum about AHIMA and their CDIP exam. I'm going to take it a step further. I'm going to say it now because I wanted to wait. I have gotten my CDI training credential. Their training program was on some foolishness.
Oh, Lord. Here come the tea, Lord.
Here's the thing. When I took my the MPCS training, you had a pre-test, and it was coded. You had to get a certain score on the pre-test to even advance into the course to get your trainer credential. Fine, no problem. They say when you take your CDIP program, which is your trainer program, that there's an assessment at the end. There's no indication of the number of questions, no indication of anything. So you have to, through the course of the program, you have to basically make sure you take the proper notes. The assessment at the end of that training program is 94 questions.
Wow.
No hint leading up to it. No kind of review. You had review at the end of the modules, but there was no kind of comprehensive, no kind of anything to even kind of let you know what you should be what you should be focusing on. It was nothing but because I know how AHIMA is on some bullcrap that I knew how to CYA, and I passed my assessment. But you should not pay $1,000 for a training program and you don't know what you're going to be tested on. That's some bullcrap. But and the kick is, this is the kicker. If you fail the assessment, you have to take the entire program again. You don't get a retest.
Wow. Yeah, we got some work to do, y'all. We have some work to do.
Clarice, remember one of your I forgot, I think it was like a month or two ago, I was telling you and Jesse that I had a friend of mine that wanted to work from home, and she was like, yeah, I want to do what you do and everything. And I gave her my old books, And when I gave her those books, she looked at me like I was crazy.
Mm-hmm.
I said, I've been doing this for some years. You don't need books. She has not mentioned nothing else about billing ever again. It takes work. It's a lot of work.
It's a lot of work.
It's hard work. Because when my friends look at me, they're like, "Oh yeah, you working from home? I think I can do that." Okay, I don't discourage them. I'm just telling you what the steps are to do. Gave her the books, and she looked at me like she saw a ghost.
Yeah, it's a lot. It's a lot. Wow. That I.
You said you gave her your book. That's it. I always look like I'm going to the airport if I move with my books. I got a little truck.
I didn't discourage her.
And I'm like, yeah, I'm carrying these books.
Hold on. I'll be back.
Okay. So we were going to segue into the kind of, I had a question that came up a couple weeks ago, and I wanted to talk about, and then as fate would have it, there is an article about transitioning from coder to auditor. So in the link in the description on I know it's on YouTube because I put it out there, but I have some links. There's like a career map from AHIMA. So it talks about the different career paths and different career things that you can go into as health information. So even if you start out as a coder, and there are a lot of people who are in health information that just coding is not their jam. They are not interested at all. Mm-hmm.
And she's training people after they pass her job hires, obviously, to do auditing.
Mm-hmm.
None of them in her group that she supervises now has ever coded.
And so some of the things we can think about as kind of an auditor and some of the skills, and really you gotta, according to this article, they make mention of, and this article was written by Rose Dunn, and she's been in this game for years and years and years. She talks about like how we, and I'm just going to speak to those who are actually coders. So once you're coding, and how do you understand how to code the cases and what to look for? So taking some of those thought processes are what you would need for the auditing hat. So, how did you get the information? What documents did you look at? Did you look at your H&P, your test reports, your radiology report, path reports, nursing notes? Oftentimes you get a lot of information from the nursing notes, so y'all need to stay over there in nursing and document them. Let me stop. Medication medication orders, etc. And so looking at those types of documents, again, bringing in the coding guidelines and your rules, because technically that's going to be your blueprint when you're auditing. Does it follow these rules? Yay or nay? That's pretty much what you have to go by. If there's a policy within a particular organization, does this information follow this policy? Yes or no? If they have a policy that you need to do XYZ, did they do it? Yes or no? And so, you have to kind of pull all of those things together when you're doing that, when you're looking at whether you're auditing a diagnosis. Did it follow the appropriate coding guidelines? Is it a combination code? And did they have the documentation to support that? When they're coding for specific procedures, do they put enough information that to allow for that particular code to be used? And is it accurate? is there additional information that may warrant a modifier if you're coding on the CPT side? So again, all of those kind of things are things that you bring into what you already know as a coder applying the code, but then you got to take a step further and think around that or above that as an auditor. And so, yeah, I thought it was a really good article. Just giving you some food for thought on if that's your jam on how to do that. And then those auditors, those roles and positions, they're all over the place. So yeah, you can be a coding auditor. You can be someone who is auditing in the compliance realm. You can be a person who's auditing data. You can be a person who's auditing from a revenue cycle perspective and making sure the revenue integrity piece is there. So there are a lot of opportunities and options related to that as well. So I thought I would share that piece. And then, like I said, on the career map, we in health information, again, there's several arms. You can go into revenue cycle management. You can go into data quality, data analytics, informatics, privacy, risk, and compliance. And so if there's a whole little map and you can click on, there's little buttons on the map, and you can click on those buttons and it further provides information on various roles that we as health information professionals can aspire to. So, I mean, I think of coding, and I've always thought of this when I got into coding, it was like a stepping stone for me. It was not necessarily the end all be all for me, because I knew that it would build to other things, and in my career it has. And when I guess maybe one day we'll walk through how my career transformed. But I think so you don't necessarily have to unless you love it. Now my thing was, once I started coding, I was like, I don't know if I can do this every day, all day, to be honest. And so while I loved it, it was interesting. I was like, I move around a lot. I don't know if I can sit at a desk like this all day. I don't know. But I saw that there were other things that were sprouting up, and I was like, oh, well, this is here's an opportunity here. Here's an option here, and again, Asha, to your point, sometimes you do have to do some of your own internal or external research to say, well, wait a minute, what's this? What does that look like? And how can I marry the two? That's one of even the thing with me getting my degree in public health. I still see a connection there. And how can I pull those pieces and the learning that I'm getting from this field into this other field? And I do still see how that works out. Mr. Jesse, you okay?
Yeah.
Okay. I know we got comments and stuff, and I can't check all of that. Hi, somebody, they said they are a medical coder. Good morning, Beja. I hope I'm saying your name right, if you're there. But yeah, that was one of the things I wanted to talk about, just how, we can transition over into those things. We don't have to settle for crumbs. That's going to be we don't have to settle for crumbs. Go get that cake. We got a recipe. We can bake our own cake.
Can I give my 2 cents on the auditing piece?
Give all your sense, sir. Yes.
What I find interesting is, like, I got my CPMA, and other than learning the legalities of auditing, learning about the Starks law, about whistleblower, about learning about the fine, safe harbor. Other than that, it really was not that. It really wasn't anything extra, because you have to audit cases, like 5 cases. But I think AAPC should really update the case that they audit, because they try to do a range, and I get that, but I think that their range could be a little more relevant to what's going on nowadays. I think that they could have a risk adjustment question. They could have, they could just move it around a lot. I think they could get a lot more variety for those 5 cases. Of course, they have an E&M. Okay, you always want to have an E&M case to audit. I understand that. But the other 4, I think they could rotate or maybe bring in some other specialties that are current, just to give the to give the credential a little more relevancy. And what a lot of people get into, and I know, but I want to talk. A lot of people get into credential hopping, and I'm telling you, my intention was not for any of it. My intention was just to gain the knowledge. And what happens is the more that's why you have to be really smart about which credentials you get, because at a certain point, a whole lot of credentials work against you in employment.
That's true.
And a lot of people don't understand that.
That's true.
I tell you, there's a certain level of job I cannot get, even though I'm audit qualified. I cannot. The amount of questions they ask me is ridiculous, because if you are an auditor and you want to work part-time on an HCC contract just for extra money, why can't, if you're an auditor, why can't you do that? But they want to get into, well, when was your most recent IRR score? Sir, I'm auditing other people's work. What do you mean? Well, you have to have a recent IRR score in at least the last 60 days. Bullcrap, foolishness. Foolishness is all it is.
What is an IRR score? For those of us in for those of us in the back.
In risk adjustment, they call the IRR score is the initial something. It's the score that you get when you do your first initial review, and it stands for some kind of response. Initial something response. I can Google it real fast.
So is it to the individual or is it to the organization?
It's you're basically accuracy for the month. And when you work with risk adjustment, you get an IRR score every month.
From the organization or from, okay. So you have had to work with an organization that will provide you that information.
Yeah, like when you work at my job, when I was before I started auditing, every month they would audit 10 of my charts. And then that would be my IRR score for the month, because for risk adjustment you have to maintain at least a 95% accuracy. So they tell you your accuracy and your you get 2 scores. You get an accuracy score, then you get a productivity score. Like how many charts you do per hour.
So that's so that gatekeeping piece right there is you have to have had work experience in order to get these scores, correct? Right. Mm-hmm.
I worked at a place where I worked for 5 years. That's what they did. I got an IRR score every month for 5 years. But since I had left and I've gone on to other roles, now when I have tried, I don't even do it anymore because it's useless. But when I have tried for extra money, or I'll get an email, they have a contract for a month or 2 months. I can't get it, because they always go back to, well, when is the last time you got a productivity score in risk adjustment? What does it matter? I have now 8 years in the game. Are you kidding me?
That's interesting. So that's another piece. Yeah. I feel my nostrils flaring again. I'm sorry.
Private company?
And what?
This is a private company?
Yes.
Oh. Interesting.
It just happened 2 weeks ago.
Oh, wow. I remember you mentioning because I didn't even know what any of that was just yet. But I've been tuning in and listening. But yeah, I'm surprised that they did that. But I also think it depends on who you know, because some of the private companies, if you get in because you know somebody that knows somebody, those little things don't matter.
That's right.
I do think it matters what you look like. I do think it matters. Like when I go in for an interview and the folks at the desk smile when they look up and see you coming, that's a safe place. When you walk in and nobody wants to look up and they roll their eyes, you just come in for an interview. That usually, to me, even before the interview starts, if this is going to be a problem situation, this is not a healthy work environment. If I don't see a lot of different kinds of people, not necessarily all people that look like me, that's a problem. I know it's not going to be a healthy environment, but I think those are things that we have to talk to folks about when they're going out to work, and even if you're working virtual. I've seen some of the virtual gatekeepers and the numbers that they want people to keep from home, or what cases they keep and how their work, and it's like they just kind of want you to quit.
Right. They're setting you up for failure. They're setting you up for failure. I've heard that too, where you have cases that are supposedly randomly assigned, but somehow one person may be getting easier cases versus another person who's getting harder cases, and the expectation of productivity is the same. There's a lot of foolishness going on in this world. But I think we also have an opportunity to provide guidance and information to our folks coming into this profession and coming along in this profession, to kind of prepare them for this level of foolishness too. It's ridiculous. Look, y'all should see my notes today, Lord.
Inter-rater reliability. Inter-RATR reliability.
Wow.
Okay.
And you get that month.
Okay. Interesting.
So now along that tax though, if you then get good at that, right? And you then open your own LLC and you say with some private doctors or offices or whatever that you want to be a professional auditor, or however that works. And that's where my issue goes back to when it comes to teaching and preparing. Now you have this individual who clearly is smart enough to understand the game politically and has strategized their own personal career where they can skim and create another income for themselves and another opportunity. But now it looks like this is, the cream of the crop, but not necessarily. You know what I mean?
Right.
Like they had learned to do that because they have created their own lane, but it's an exclusive lane for themselves and who they see fit.
Right, but you kind of mentioned you kind of have an overlap somewhere, because you can create your own LLC. 'Tis true, but you can't just go around contacting physician practices, because a lot of them are under larger umbrellas, and the larger umbrellas actually provide the auditing for them. They only send in the information that their larger insurance company will request, and then their larger insurance company, whoever they're affiliated with, they have a contract with a coding with some kind of auditing agency to do it for them. It's not done on like that local of a level anymore. I'm not saying it's not done, because the country's huge, but in larger areas, I don't think that's so much the case. So there will always be some private practices, but you would have to really find a private practice that's not affiliated with like an Aetna or like with a Cigna, be under their umbrella.
But that's just specific to HCC, right? And risk adjustment coding. Because any other type of auditing, you can't. I mean, trust me, they call me. The providers call me, and it's like we have an issue, and primarily it's around their documentation. And we have an issue with documentation. We have providers that we need to understand what that documentation is, and does it support the levels that they're billing. And so they're calling the external auditors to come in and assist and help. So that we don't deal with we don't deal with that. Again, they call me for whatever type of organization it is, whatever specialty. Typically you're looking at their E&M services. Some of them are urgent care services. Some of them are in the behavioral health space. I've done some recent lab work, some base, which is gonna be a doozy. But yeah.
Right, but my question is, what size is the group? Because what has happened over the past couple of years is because there was a trend where these larger insurance companies scooped up all these smaller practices. Now you have into a breaking of what.
So again, these are not anything with risk adjustment. So most of my practices, I go from either smaller individual practices to practices or organizations that are nationwide, and they have offices and facilities in different states, which is a whole other headache, because then I have to make sure I do the research on those particular states, because primarily they're billing, particularly in the behavioral health space, they're billing Medicaid. And most of their guidance is state specific. So while they may have their corporate office in one state, they may have hands and arms in multiple states across the country. And so and they're not saying, oh, we want you to just take a look at this one office. They want it across their organization. So again, you have to make sure that you understand what those rules and guidelines for their state Medicaid offices are. But yeah, so it's all over the place. It's all over the place. But yeah, they will contact you. So if you are quote unquote, and I say quote unquote, but if you are the expert in that space, or you are known as an auditor in those spaces, they're knocking on the door. They're calling you. They're like, hey, we need XYZ. We need assistance. And then from that, you also, not only can you come in and do the auditing piece for it, but oftentimes they want you to provide the education. And so sometimes it's a matter of come in, educate us, or do a baseline, come in, do some education, and then go back and do a follow-up audit. And sometimes that can be a one-time engagement. It can be a multiple year engagement where, quarterly, we need you to come in and look at these records, or on an annual basis. Mm-hmm.
They look at what they charge mostly.
Mm-hmm.
They look at where their denials are coming from.
Mm-hmm.
Denials. They're looking at how they can increase what they pull in, because maybe they can be billing this instead of that specialty. So the audits could be for anything, not just risk analysis.
Correct.
It's their overall revenue, and then
correct.
Doctors, physicians, the front end.
Correct.
And that education part is absolutely key, because the young lady I'm actually referencing, that's actually her sweet spot. She needs to go in and talk to the doctor, talk to the group of doctors as to what codes are working for them with the billing. And then what is a higher code for the similar service that they can bill to increase their revenue, and that's a sweet spot.
And looking at their documentation and seeing where there are opportunities, because oftentimes they have some things there. They don't, depending on the practice, sometimes they have them quote unquote code their services, and sometimes they have a coder. So if the organization requires the provider to code, they have absolutely no idea. They're not taught coding. And so this is an opportunity for them to kind of get a baseline understanding. If these are the types of services that you're providing, if this is what that looks like, oftentimes this is the level of service that you're providing. And so providing them a level of comfort and understanding based on how that patient is presenting and the services that they're providing, this is what your services look like, versus I have no idea. I'm looking like a deer in the headlights, and I'm kind of eating meeny miny mo. Let me pick this one and go. And it's like, no, there is a method to all of this madness that we're doing, and then providing them the education. Another thing that they actually do too, because they may not necessarily have the resources when they acquire new practices. If they're looking at acquiring new practices, they need some due diligence work. They may have people come in and say, look, they told us they getting all this money and this, that, and the other, and this is what they're billing and blah, blah, blah. And we need somebody to check that. We need somebody to validate that. So I've worked with private capital firms to assist them in that due diligence work. So they're like, well, can you take a look at their stuff and match and see, does it, does it jive with whatever? So that provides them some data on whether or not they want to proceed with that acquisition, or what, maybe we need to pull back or what have you. But then it also gives them information on what they need to do going forward. And then you also have, when they're just hiring new people, please get them up to speed on what we do and how they need to do it, because as we all know, this stuff is not provided to them in medical school. And so help them understand how their documentation translates to our bottom line. And so you have those conversations and you teach and train that way as well. So yeah, there's a lot of stuff out here to do.
Yeah, we actually pull super bills for certain doctors, especially the new doctors that just got put to the side for what we call the coder.
Yep.
I understood, coming out of, all of my investigations, that, it's a new doctor. He's basically being trained to make sure he's coding efficiently for this group of that he's now entered in.
Yep.
They accepted him in. He's got clearly a new specialty, a skill, and a following, and they want to make sure he's coding appropriately for our, situation. But yeah, that made perfect sense to me.
Yep, that's what they do.
Wait, so when you say coding appropriately, do you mean diagnosing appropriately or physically coding appropriately?
Probably a little bit of both.
It's a little bit.
A lot of doctors, what they use wherever they came from versus what we use, or use in the office that I worked in, is they have a different, or they don't have any experience at all. So if they're coming into us and they're not used to coding, they're gonna do whatever according to the super bill, check off anything or not check off enough. So the coder will go back to the doctor's notes, and that's another thing. A lot of doctors, for some reason, aren't used to doing their own notes. I don't know what that's about, but it is a thing. Or doing notes properly according to how our system works at that agency. And so the coder comes into that particular doctor who's new, maybe 3 months or more, and looks at their notes and makes sure and looks at every single super bill to make sure that it's going the way it should go. And that particular auditor, if it's how we expressed before, they know the higher ranges of what that doctor could be coding for each patient, to then bringing more money to the establishment or to get that doctor higher paid.
Yep.
So it kind of goes both ways. And then you're having the conversation now with the doctor to show them, this is what you did, this is what I did. And gradually you see after about 2 or 3 months, the doctor kind of picks up on the regular code that they want them to use.
Yep.
But can I tell you, I mean, this is just a hill I'm willing to die on. I don't believe that providers should be told how to code, because they're never going to get it right. Unless a provider goes and gets a coding credential, they will never know how to code appropriately. The better is just in provider education, where you teach them about the combination codes, where you teach them about the causal relationships. Then that way they can. I think that's a whole lot easier than to try to get them to pick I-12.0 versus I-12.9.
But Jesse, here's the thing. To your point, that is true. However, primarily what they're interested in them coding is their services. So this is more on the physician side, not necessarily on the hospital side. So they have kind of a huge list on their super bill as it relates to, or encounter form as it relates to the various diagnoses, depending on that practice or depending on that specialty. So they kind of get a feel for what those diagnoses are. And unfortunately, or fortunately, depending on that practitioner, how they document the specificity kind of alters that. Their focus is, because on the physician side, they're not paid based on the diagnosis per se, unless you're looking again at risk adjustment stuff. They're paid based on the services they're providing. And so they want them to get an understanding, particularly around the evaluation and management services, on how to code that. And that is what they're kind of pressing on with these providers. You have to know, you have to have an understanding of what these levels of services look like when it walks through the door, so that you can document appropriately and code appropriately. that's where they're forcing their hand on, you need to know this, and they want them to quote unquote code this when it comes through. And when they have these electronic medical record, these EMRs, sometimes they have AI in these EMRs that are quote unquote coding them for them. And so they also need to understand, the AI system said this, well, what really is it? And make sure that they are adjusting them appropriately as well. Because if they're like, oh, well, I think I'm gonna follow what the AI said, and they don't even have enough stuff really to validate not only the code, but the medical necessity of the code, that's a problem. And so they need to understand that piece, and that's what the training and education provides for them. So yeah, you're right, down to the nitty gritty of understanding like the coding guideline related to this and related to that for diagnosis coding. Probably absolutely not. That'll never happen. But
But that's what some places expect. And I understand that you have to code for your services, absolutely. I mean, if you have done, because of exam, by all means, document appropriately so you can be paid for the exam. But in your E&M, reflectable now that they changed, I mean, it really doesn't much matter.
It still matters. Don't do that. Don't do that. Don't do that, sir. It still matters. It's a little different, but it still matters. And we're right now sitting in the middle of two guidelines. You're sitting in the middle of two rules, depending on your side of service. So it still matters.
But if you say an adequate history, an adequate exam, but your final decision is either going to be medical making or time, that's not nearly as intensive as having to double.
Don't believe that. Don't believe that foolishness.
But
don't believe that.
But what does adequate mean?
So so just like you had to walk through what the history and the exam portions are, you should have always walked through. Well, that's a whole other conversation. We'll be here for another hour. That you should have always walked through medical. You should have always walked through medical decision making, because it's easy to click off all these boxes for history, and it's easy to click all these boxes for exam. Your medical decision making supports the medical necessity for what those services are, and so you still have to quote unquote kind of count up what's going on. What did they document related to their thought process on medical decision making based on the presentation of that patient? So you still got that same, it's not as easy breezy as you think. And a lot of services, particularly in behavioral health, y'all know that's my bread and butter right there. Particularly in behavioral health, nobody is playing with that time, because that time is going to get you in trouble, because your time, you have your schedule, you have all of this stuff, and there are time parameters, but really they're going in, they're maybe spending 15 minutes, maybe 8 minutes, maybe 5 minutes with that patient. However, they're doing services that would still warrant a higher level of service. So again, most of them are shying away from that time, and they're actually using the medical decision-making components to level their service. And you have to know what those things are in order to support those codes that they're billing. So no, it's not as easy as, oh, we're going to do this or put some time on it. No, sir. No, sir. We'll be working for years. Trust me.
Behavioral health really is kind of in its own little space, because they have a whole lot of stuff going on. And I think it's a little different than regular services.
No, it's not. It's still not. It's still not.
Because the difference is, like this is me. When I audited behavioral health, we, like you said, document time. It is not only time, because you have to look at what was done, and they have to meet certain criteria even within that time. If you documented that you did 4 interventions, but you only documented 2, that's not enough. Like you can only be paid for the 2. You can't, because that's upcoded. It's a mismatch, because you have to have an intervention. And like you said, when it's on the state, there's the state criteria. The state that I had, South Carolina, for instance, for each intervention that you have documented, you have to document the outcome or the response to that intervention. So if you don't document every intervention you did, it doesn't matter that you were there an hour or whatever. If you don't document, you still can't get credit for that. That encounter still gets kicked back because you have to fix it. You got to straighten it out. So I'm saying that makes perfect sense. But if you have this new, because I mean, truthfully, I haven't even audited. I haven't even done any coding under this new ENF other than what I read just for my CEUs. But if the criteria is medical decision making and or time, how then? Because all this says is an appropriate or an adequate or appropriate history and exam. What does that mean?
It doesn't matter because your appropriate or adequate history or exam does not factor in the level of service of your E&M code. It doesn't. So that's the appropriate is appropriate to the condition that the patient is presenting with and what that provider chooses to document. What's going to give them their level is that medical decision making and making sure that they are documenting to the spirit of what those elements are for those particular levels of service. That's what's going to carry them. So that's what they need to document because it was a, how did they say? A burden to the providers to continuously, I don't know how it's a burden because hell, they was all copying and pasting anyway, but that's the whole, or clicking some buttons, but but this is where, and this is where for me, like I've always, even in teaching and talking with providers, told them you need your medical decision making should always be one of those key elements that you are basing your level, basing your code selection on. Never do you just use your history and exam. That was foolishness. And there are a lot of people that believe that. And I was like, that's not going to carry you through because they're going to look and you can document all day long, a beautiful, long-winded history and hit every body system in the world, and that person is coming in with a code that doesn't justify or that doesn't provide any medically necessary information on why you did that extensive exam and why you took the time to get that long, beautiful, flowery history because they're just coming in with a code. No, ma'am, and no, sir. That's your medical decision making, which is one of the reasons why they honed in on that element to provide that level of service. Again, it helps to determine, what that patient is, because again, their job is to give the information about that patient. Their job is to be the historian. Their job is to give their objective assessment of what is happening with that patient, not only for that patient's sake and caring for them, but also providing information to other providers who may be caring for that patient as well, and interactions and all those things, because they could be on multiple medications and have multiple diagnoses. And so they have to make sure that they're providing the necessary information and documentation that speaks to all of that. But so in that realm, their medical decision-making is key. And then as far as payment and reimbursement, they're matching it. So if from an auditor perspective on that realm, that Medicaid, that Medicaid managed care company, that even that third party payer, they're looking to see whether or not there is information that is sufficient to say this was a medically necessary service that happened, and yes, we should pay it. Does that documentation support that this is a medically necessary service at that level of service? They provided that level of service based on that documentation. And so it's a whole little circle there that you have to make sure that all of those things are matched within that documentation. Physicians don't necessarily understand and know that, but they're learning that. And that's what these organizations want their physicians coming in to know, because they don't and I'll be honest, they don't necessarily want to hire a whole bunch of coders to do that. They got services going out the wazoo. They are expanding. They're seeing patients on a much higher frequency than coders probably can push that stuff out. They want their money. And they want their money now. And they want to be able to click that button and let all them claims flow. And they want to feel comfortable that those claims are accurate as they're going out the door. So they want to make sure that they on the front end are providing the information and knowledge to those providers that, yeah, you know. And then because in the organizations I've dealt with, there's some repercussions if these providers are not getting it. You're not getting it, we might not be paying you your money. You may not be getting your bonuses. You may not be getting your salaries. You're not getting paid on time, or we may be letting you go. So there are some repercussions. Exactly. There are some repercussions to these providers if they are not getting it. And so we've invested time, energy, and money into getting you to where you need to be in order to document to the level of services that of the patients that you're seeing. By all means, you need to be taking advantage of that and doing that. And if you cannot or do that, like Asha said, this may not be for you. You may not be a good fit for this organization.
About the medical decision making. I think I mentioned this before because I used to work for a psychiatry clinic, and I had to school. I had to school the provider and let him know you have a returning. He of course, providers are looking at the money aspect, but we also your records documentation has to match, especially with the Medicaid, the Medicaid payers. Payers. He was he had a follow-up patient coming in, anxiety. Oh, it's a follow-up, not a follow-up, but you want to code the highest 99214. And he kept asking, well, why is Medicaid denied? I'm like, well, your documentation doesn't match. This is a follow-up patient with anxiety. So what's different from the other visit? When the patient came in, did the patient display a new diagnosis? So I had to, educate him. It was hard, but you're right, Clarice.
But that I do understand it, but that's providers all across the board. All of them have to be trained. None of them are right. And most of them don't listen anyway. That's why they're losing money. Most of them never really get it. It takes them a while anyway. So we all understand medical necessity. The medical decision making, because that ties medical necessity with has always been fiber. But it's how you got there with the whole other history element, history leveling, exam level, and then combine that with the medical decision making level. So that's my whole. That was the whole point of what I was saying. Like now, it seems like, and it does, but it's not. It does. Exam. It's not the focus. Like it doesn't have the same weight in calculation that it used to have, because it just doesn't.
It doesn't.
Because there's no way to factor it in. But I see, Clarice, in the chat, Sam Aurora has posted, in case anyone knows coders looking, he's hiring on-site coders in Oklahoma, Texas, Virginia, and Nebraska, and will pay for them to get a CEMA certification if they don't already have it. And there's a link, a website attached to the message.
Here, I put that out. My bad. Okay. I was going to try to type in that link into the, it's jobs.auroragroup.com for those who may be interested.
Thank you again, Sam.
Thank you, Sam. I tried to get him to speak. He couldn't come.
And while you're doing that, Beja had a comment when we were talking about productivity and scores from what, to piggyback off of what Asha was saying. And she said, please talk about that ways to combat those issues. And she said, I would love to learn how to navigate through scenarios like that. I had a situation like that, like you said, productivity can be manipulated. And what happens is your productivity score should be based off of two things. It should be based off of your your productivity per hour, whatever the rate is per hour for chart review for that particular project. But if you do not meet that requirement, the next requirement should be page count. You should be reviewing X number of pages per hour. That's how they do it for risk adjustment. You should be reviewing X number of pages per hour to make just so they can prove that you are working at a pace. Because sometimes you can't if you're working through a large chart. I've had charts of like 4,000 pages. So you're not going to finish a 4,000 page chart in a day, but you have to work. But your work should show that it will reflect. And this software can tell how many pages you reviewed because it tracks everything. So I had a problem with this one particular supervisor I had. And this particular project, the chart requirement was one per hour because that's how detailed it was. And um, nobody consistently across a project, the overall score was below one because you have no idea how many pages you'll get. Now, typically that project, the pages kind of capped at around 60, but it could take you an hour to do 20 pages because they capture everything. I mean, signs, symptoms, everything, in addition to diagnosis. So she, when I had my review, she was like, "Well, you're not meeting productivity." So I said, "Well, what's my page count? How many pages am I doing per hour?" So she was like, "Well, that doesn't matter because there are other people who are doing it." I said, "But that's not what I asked you." I said, "I asked you what was my page count." Well, like I said, that doesn't matter. I said, "But it does matter because that's the other criteria that you're supposed to use." And I told her, "Listen, I'm not new. I'm not a new employee. I'm new to your team, but I've been here a while, just like you have. That's how it goes." And I told her, I said, "And I also know," I said, "that you can't compare somebody because I would be willing to bet that that person who is meeting criteria, they only have 15-page charts. I can do a 15-page chart in a half hour at this rate because I mean you get the flow." So if we went back and forth, then next thing I know, all of a sudden, for 3 days, I didn't get a chart over 10 pages.
You done bullied them.
Then after that, I got reassigned.
Wow. Yeah, I had heard something kind of similar. They were in this particular organization, people were given, and like I said, that's where it was supposedly randomly assigned in their queue. But for whatever reason, a person was receiving like all of the cardiology cases, and that's gonna take some time, some skill, some digging in, versus someone who's getting all the like the general practitioner assignments where you can kind of quickly easily brush through that. And it was like, and that person, the cardiology, she wasn't necessarily a cardiology specialist. She did well in them, but it was like, well, wait a minute, why can't I get some easy breezy stuff too, that helps along? And they weren't necessarily dinging her on her productivity because they knew the types of codes that she was getting. But when they put it all, because in some of these meetings they will display everybody's business right there. I don't That's a whole other conversation, but they would display everybody's business on productivity, and hers was always less. And it was like, but you always had to give this caveat: look at the types of charts that she's getting, and you have to explain, look at the type of charts that y'all putting in, somebody is putting into my queue based on some of these others. And it's like, so that's some of the things that some gatekeeping is happening as it relates to what types of things that you're getting. But it could, for her, it was kind of, it worked in her favor, but I can see where it would work the opposite in somebody else, because then they may be saying, well, you're not meeting your productivity. And if they don't know or not savvy enough to know, well, wait a minute, let's take a look at the types of cases versus well, Dad, you're right. And then they work themselves to death and burn out, not knowing you need to take into account all of the factors and not just, you're provided this many cases in a queue and this is what your expectations are for the day versus, okay, I had to spend more time because the specialty of the cases that you're providing me. So, yeah.
I just wanted to recap for Bangkok, for Asia Math. Basically, what you want to do with whatever your quota is or your productivity rate is, you want to find out what additional criteria do they use, because they should use an additional criteria. Normally, it's page count to kind of help you, bolster or reinforce that you really are working, but you're just having difficult cases that require more. So that's how I would navigate it, and I would make sure that you get it and get some kind of information in writing, because you never want things to be just state, because people get amnesia real quick.
Oh, Lord. Everything needs to be in writing. Jesus, make sure it all is in writing. Woo. That's a CYA all day. Make sure it's in writing.
And also another thing, like, Clarice, like the conversation we had in the past, like 15 minutes, there is no publication out here that's telling coders that's how, those are avenues of employment to pursue. Like, it's just, the industry needs to do a better job.
You're right. And I think that's what I'm gonna put on for at least for my state advocacy direction is let's talk a little bit more. I know you're talking, because right now we're doing actual recruitment and retention into the programs, but what happens after that? After they're done with the program, what happens after they're met with resistance in securing a position? What happens once they get a position and they're met with these microaggressions and all this other foolishness? What happens when they got to compete with all these nurses and the influx of nurses that are going to be coming in? What happens? And so somebody needs to tell those stories. Somebody needs to. I mean, we're telling those stories here, so send them over here. We got all kinds of stuff for you. Right.
I don't know if
I don't know somebody. Somebody wasn't born yet, at least not with that name. Can we do that? Can we talk about how we could probably do something like that?
Oh, we could. Yes, ma'am.
I even know builders that are saying the same thing. They're encouraged to, work for companies, but they're also encouraged maybe to go out and do their own thing. And now they're all of these individual companies with billers, and they're like, well, is there a national conference for us as business owners? Like that's definitely.
I see a conference in my future. Where we going?
I don't know, but I'm just saying. You have a newsletter, and you have a conference, and you have training, and you have. You see what I'm saying? I feel like that because we are all companies at least here, and I don't know who else is here.
You better stop, Asha.
Like it wasn't no report.
I'm
just saying there could be an offline. I know when I first came, you guys were offline, but like I think that for somebody, or the people that are saying somebody, could create a lane like this.
Yes.
Supportive to the others that are in their lane.
Clarice, what I want to say is, I don't know if you are going to announce who the guest is going to be, but
I was getting to that.
He would be a good person to have our conversation about gatekeeping, because he himself has talked about, because he has his credentials, and he was saying how hard it was for him to get a job in CDIP because he wasn't a nurse. He was even talking about nursing school to get a degree to get into CDI, which is totally unnecessary. It should be, especially when you have he has some hefty credentials.
Okay. Well, then we'll segue because we way over time today, but it's been juicy and tea spilling and worthy and all of those wonderful things. So yes. And Miss Asha, girl, we gonna connect. We gonna get together because I see the stage. Look, we just got to figure out at what city we coming. Maybe we'll make it a tour at a city near you. Right. At a city near you. Come on, y'all. Oh, and or virtually. Look at God. It's okay. See, okay. Anyway, let me come back. Focus. So next week we are having the medical coding geek join us as our guest to talk about, as Mr. Jesse said, his experiences with the 2022 word of the year, gatekeeping, as well as I know we have had some folks interested in finding out where they can get free and low cost CEUs. And he has this running list. He does it, I believe it's a monthly list that he pulls all of this information and provides that. And so we're going to have him on kind of giving us a little bit about his background, what he does, and information regarding that list. So stay tuned. We'll push some information out. Share, tell a friend, bring a mile lover. Whether you're watching on YouTube, Facebook, or if you're listening in on Clubhouse, feel free to come in and join the conversation with us as we talk to the medical coding geek. And I don't want to butcher his last name. That's why I didn't say it. So we're going to keep him at the medical coding geek until he comes on. And so with that, yes, thank you, Vicky. And thank you for staying with us. I think you've been here the entire time. And so we appreciate you. Happy Mother's Day as well. And thank you. I hope to do absolutely nothing on this Mother's Day. I'm actually doing things for my mom today so that it'll be all about me tomorrow. Happy Mother's Day to all of the mothers. And so, again, Mr. Jesse, was the tea spilled today?
Spilled, mopped up, and spilled again.
Asha, look, we're going to put you on moderator row as well. Was the tea spilled today? She even spilled tea. It was great. So if this information was valuable and helpful for you, again, help us share this message. We already got a task. We need to make sure we're educating these folks about what it looks like once they get over that certification hurdle. Yes, one thing to be certified, but it's something totally different to be working in this industry, in this field. And so I'm tasking everybody. We all have an obligation to make sure that we bring a friend. So you can also share this. You can share this information by liking the video, sharing the video, and subscribing to the channel, Professional Reimbursement Network. You can also check out the Coding Nurse channel on YouTube, where Mr. Jesse spills some additional tea and crumbs and all of the things over on his channel as well, and provide information on his upcoming classes and programs. Last but certainly not least, to my Clubhouse folks, we are a community right in here, and there are all kinds of resources right here in our Clubhouse community. So click on that green Clubhouse. So you can join in the fun and network with each other, follow each other, connect. You never know who's in what room and what information may be spilled in those rooms that we need to talk about over here, and we can provide some perspective as well. So again, network with each other and become a member of the club. Plus, you'll get notified when we go live, which is typically every Saturday morning at 9 a.m. Eastern Standard Time. I was in my feelings because I didn't get to do my little music and all of those things because computer just completely died. I think it wasn't plugged in. And so that's why we didn't get the stuff at the beginning. But we made up for it, trust and believe, with the information that we provided today. Mr. Jesse, did you have any additional last words?
As always, I'm glad you created this space. I'm thankful for it. And I'm glad to connect with like-minded people who love the number one, are really trying to add value to our industry. I love it.
And look at the change leaders, not a-holes, but change leaders. And change agents and thought leaders that we have within our group. Look at God. Won't he bring you? Won't he bring it what you need? Yes. So, so this has been a great session today. Thank you all for joining us. And remember, be safe, be kind, and don't wish for it, work for it. Until next Saturday, take care. Have a great weekend. Happy Mother's Day and all the good things. All right. Bye-bye.